Well, good afternoon, and welcome to Samaritan's Purse International Health Forum, and thank you for joining us today. We hope you all participate in the conversation. You can chat with us in the chat box beside the video. Before we begin this afternoon, let's open in a word of prayer. Dear Lord, thank you for this day. Thank you for the blessings that you continue to provide. Thank you for our speaker this afternoon, and we ask your blessing on his presentation. We also ask for a blessing to the audience this afternoon. Thank you for health and strength continued during this COVID time, and may we be a witness to you as we represent you well during this conference. In Jesus' name, amen. Well, today we have the honor of introducing Dr. Steve Hagen to you. He is going to present Post-exposure Prophylaxis Protocol 2020, the Blood-borne Pathogen Update. That's a mouthful, Dr. Hagen. Since July of 2019, Dr. Hagen has been the family physician staffing our clinic here at Samaritan's Purse, the Wake Forest Baptist Health Family Medicine Clinic. Prior to that, he practiced more than 20 years in Appleton, Wisconsin in family medicine after completing his residency at the University of Wisconsin. He and his wife, Jill, live here in Boone now and have served on multiple disaster relief deployments with Samaritan's Purse North American Ministries. Their two sons remain in Wisconsin, where the oldest works as a technical writer for Epic Systems in Verona, and the youngest soon will start his second year at Wisconsin Lutheran Seminary. Dr. Hagen, we are so honored to have you. Thank you for joining us today.
Thank you, Tom. Very nice to be with you today. The topic today, the post-exposure prophylaxis, kind of a blood-borne pathogen update, I don't think has been done on the International Health Forum here for several years. So Samaritan's Purse and their affiliates around the world have a blood-borne pathogen protocol that was recently updated a little bit. At the end, I'll make sure that I give out some contact information for anybody who would like a copy of that protocol. So the first slide today just is the disclosures slide. I don't have any disclosures, nothing to disclose, no financial conflicts of interest. Next slide, I thought I would just start with some background information. So today we're primarily dealing with what do you do after exposure to a blood-borne pathogen, primarily HIV, hepatitis B, or hepatitis C. I thought we would start with some of the statistics about HIV globally. It is the world's leading infectious killer since the epidemic was first identified in about June of 1981. It's killed 33 million people around the world. There are about 38 million people around the world who are currently living with HIV. That's as of the end of 2019. And the vast majority of those people live in low and middle income countries. Can be transmitted sexually, can be transmitted via transfusion, vertically from mother to fetus, and also by occupational exposures, primarily percutaneous puncture wounds. For healthcare providers, by far the largest risk comes from needle sticks, mainly hollow bore needles, much more so than solid suture needles. Also blood splashes or blood exposed to lacerated or abraded skin or mucosal surfaces. But with a needle stick, the risk is considered to be about 0.3%, maybe about 1 in 300. The questions at the end of the presentation that may come up. Transmission due to small amounts of blood on intact skin has actually never been documented. Risk of exposure of blood or bodily fluids to intact mucous membranes is also considered by the WHO to be negligible. It's fortunate that HIV can't survive outside the body, outside a host, for more than a couple of hours, and that simple desiccation eliminates inactive viruses, inactivates any active HIV virus, in contrast to especially hepatitis B, as we'll see next. So next slide. Hepatitis B is a cause of both acute and chronic liver disease. The incubation period averages about 90 days, but it can be as short as 30 days or as long as 180 days. Acutely, most infected individuals who've been exposed to hepatitis B remain asymptomatic. A minority of them do become moderately ill, almost like somebody with acute hepatitis A, with fever, malaise, anorexia, nausea, vomiting, abdominal pain, jaundice, and only a small percentage of those folks will progress to fulminant hepatic failure. Most individuals infected with hepatitis B will clear the infection, will clear the virus spontaneously. This is in contrast to hepatitis C, as we'll see in a little bit. So if chronic infection with resultant inflammation does develop with hepatitis B, there are antiviral medications that can help minimize the risk of progression to cirrhosis with all of its complications, including hepatocellular carcinoma. Some additional background on hepatitis B, the next slide. It's a little bit scary to think that a third of the world's population has had hepatitis B at some point, and that 350 million people around the world, which is more than the population of the United States, are carriers of hepatitis B, with about 600,000 people dying annually from complications due to hepatitis B. It's by far the most infectious of these three viruses we're discussing today. It's 50 to 100 times more infectious than HIV. Can also be transmitted sexually via contaminated transfusions, vertically from mother to fetus, via human bites, and also via percutaneous and mucosal exposures, including things like as simple as sharing a toothbrush. But certainly with improperly sterilized surgical instruments or endoscopes. It does survive on environmental surfaces for up to 7 days. Fortunately, there's a vaccine for hepatitis B. We recommend that healthcare providers who have been vaccinated periodically ask their primary care physician to check a quantitative hepatitis B surface antibody titer, because a titer greater than 10 milli-international units per milliliter, a titer greater than 10 is considered to be protective. So if somebody is in the field and they happen to be exposed to a hepatitis B carrier and they know their titer, it's been checked recently and it's greater than 10, they don't necessarily have to jump through a bunch of additional hoops as regards to hepatitis B. Next slide. With hepatitis C, the existence of hepatitis C, as you all know, was suspected for many years, but it was not definitively identified until 1989. The first blood test to detect antibodies to hepatitis C didn't really become available until 1992 to render the blood supply much safer. Primarily, hepatitis C is spread via intravenous drug use, via contaminated transfusion, inadequately sterilized medical equipment, and also, for our purposes today, via occupational exposure through needle sticks and so forth. It can be spread vertically from mother to fetus, although that occurs in less than 10% of pregnancies in which the mother is actually RNA positive for hepatitis C. It's still a bit controversial whether or not hepatitis C is transmitted sexually. So for people with hepatitis C, most individuals acutely infected with hepatitis C have no symptoms at all. That makes it quite stealthy, and somewhere in the neighborhood of 60 to 80% of people who contract hepatitis C will go on to have chronic infection, which is kind of the opposite of the case with hepatitis B. Globally, the World Health Organization estimates that there are about 70 plus million people living with chronic hepatitis C infection. And 2016, the most recent year that we have good data for, an estimated 400,000 people died from cirrhosis or hepatocellular carcinoma resulting from hepatitis C. I've read some different numbers even just recently as far as the risk of seroconversion after a high-risk occupational exposure, meaning kind of a deep inoculation from a hollow-bore needle. They used to think that it was 1.8 to 2% risk of contracting hepatitis C, but the most recent guideline that came out from the CDC about hepatitis C said that it is probably more like 0.2%, the risk from a single needle stick in that way. And hepatitis C can survive on environmental surfaces for up to 16 hours, and of course, on hypodermic needles and surgical instruments. So next slide. So in terms of today's talk, who are the targets of this information? It is World Medical Mission volunteers at World Meds hospitals around the world, the post-residency program providers, the medical DART providers, when we have big disaster responses around the world, and then any other Samaritan's Purse staff who might be exposed to bodily fluids in the course of performing their duties. Next slide. As far as why is this important, it's important because post-exposure prophylaxis significantly reduces the risk of HIV infection through the means of antiretroviral medication. It's also important because especially with HIV exposure, it's essential that post-exposure prophylaxis start within 72 hours, hopefully much sooner than that if you have somebody who is known to be HIV positive as a source patient. And also occupational exposure to hepatitis B and or hepatitis C involves some additional precautionary measures and follow-up that we'll go over in a little bit. So, as far as the how might one be exposed occupationally to blood-borne pathogens? We're mainly talking about sharps. There's a big difference between hollow bore needles that have already been inside somebody's vein or inside a source patient's body versus solid surgical needles that don't really have a place for a reservoir of source patient blood. Scalpel blades, OR instruments can certainly get bloody, and if you've ever been stabbed with a scalpel blade, they can go pretty deep. Splashes on mucous membranes or on broken skin, especially broken skin, abraded or lacerated skin, blood splashes can be scary. I know when I was in medical school, little vignette here, we were at the VA hospital in Chicago doing a FemPop bypass on somebody. And for reasons I still don't understand, while one of the junior residents had their face right down next to the surgical wound, the chief resident took the clamp off of the patient's femoral artery and just like a garden hose gave the junior resident a face full of arterial blood from a patient. And I know they did all the follow-up testing that should have been done in that situation, but that was in the days before there was a blood test for hepatitis C, so that probably would have made me a little nervous if I was that individual. So though the overall risk of transmission is low, the consequences from any one of these viruses going undetected, unnoticed, and being allowed to progress is really quite significant. And again, time is of the essence in terms of getting post-exposure prophylaxis started, especially in the case of HIV. So Occupational exposure, the priorities initially, and the protocol packet that we have available explains a lot of these things in a lot more detail than I will, but properly cleaning and disinfecting the exposure site is really important. Documenting the exposure event, having people that are unafraid to report it is really important, because the sooner the details of the event can be recorded, the more likely they are to be accurate. Getting an accurate medical history and a physical exam for both the exposed individual and the source patient is really important. Quickly completing rapid antigen antibody testing on both the source patient and the exposed staff member as a baseline is also quite important. Obtaining appropriate informed consent before you do any of the testing is also important. We'll go over that in a little bit. Initiating post-exposure prophylaxis within 72 hours, but preferably within 24 to 36 hours is high on the priority list. And if the source patient is known to be HIV positive, just the sooner the first dose of that antiretroviral medication can get into the exposed staffer, the better. One item that may be new to folks compared to the last time this was presented was a per Samaritan's Purse policy. If immediate arrangements could be made for exposed staff members to return to their country of origin, just to really ensure that they have an uninterrupted course of post-exposure prophylaxis, especially in the case of HIV. I know that some of the old road warriors that have spent a lot of time overseas, spent a lot of time in underserved communities and countries around the world, the idea of leaving the field is to go home to take their post-exposure prophylaxis is kind of anathema. If they're working in an area where they know they will have an uninterrupted supply of appropriate post-exposure prophylaxis, and they will have access to reliable follow-up testing. There may be some exceptions to that policy, but I know that the leadership with World Medical Mission and the leadership at Samaritan's Purse would really prefer that those arrangements be made. So next slide. As far as counseling and consent go, both the source patient and the exposed staff member should be made aware of the psychosocial support and counseling services that can be provided by Samaritan's Purse, that would be provided by Samaritan's Purse in the event of an occupational exposure, regardless of whether the exposed staff member chooses to return home or remain in the field. Samaritan's Purse will certainly provide appropriate Christian counseling for that individual. The counseling guidelines and the informed consent information for both the source patient and the exposed staff member are included in this protocol packet that we have for distribution, and those are in attachments A through C. So some of the highlights of counseling and consent. The counseling in advance of testing is really essential to the informed consent process. Also, it's essential, I think, for just the emotional and spiritual support of both parties, especially if the circumstances of that exposure were particularly traumatic. It should be done in a quiet, private space to maximize confidentiality and to encourage both the source patient and the exposed staff member to be able to ask questions and to be able to talk about the event. If either party does have questions for the individual doing the counseling, for the individual obtaining the informed consent, that the counselor really does not know the answer to, don't hesitate to explain, I don't know the answer to that question, but I will find the answer to it and get back to you. We certainly do have access to infectious disease specialists. There is a post-exposure prophylaxis hotline that can be very helpful, that is accessible 24/7, 365. And it's just also really important to follow through on any promise to get back to that individual with more information. So, and next slide, as far as some of the counseling and consent statistics, I already mentioned a couple of these, that with a needle stick or blood in an open wound, the risk of HIV transmission, even from a source patient who is known to be HIV positive, is only about 1 in 300, about 0.3%. Hollow bore needles confer much more significant risk than suture needles do. The risk is thought to be negligible with exposure to eyes, nose, mouth, as long as those mucous membranes are intact. Superficial exposure to non-intact skin is thought to be less than 0.1%, and intact skin is thought to present no risk at all. Hepatitis B is by far the most infectious of the three, but fortunately we have a vaccine for that. And we also have hepatitis B immune globulin, that if we have a known carrier source patient, that as long as the first dose of hepatitis B immune globulin is given within 14 days with a follow-up dose a month later, that should be quite protective, followed by revaccination. And then hepatitis C, even though we don't have a vaccine for hepatitis C, the risk of seroconversion is thought to be only about 0.2% from a needle stick, and really 0% from mucocutaneous exposure. Next slide. As far as the HIV evaluation of a source patient, we'd like to get the rapid HIV antigen antibody testing done just as soon as possible after the exposure event. It's important to get consent from the patient. At some World Medical Mission facilities, they do have post-exposure prophylaxis kits, although at certainly not nearly all of them. Just, I think, because of the expiration dates of the antiretroviral medication, and even the expiration dates and the expense of the little rapid test kits that are in those PEP kits, that initiative and how widely that gets rolled out is still kind of pending. If the source patient tests negative, but there is high clinical suspicion just based on prevalence in the local population or other factors, it's important to conduct HIV RNA PCR testing if that's available. If that is not available, it's always best to assume that the source patient is HIV positive, and but if their rapid diagnostic test is positive, it's important to confirm that with a Western blot, but don't ever delay the initiation of antiretroviral medication while waiting for that Western blot result to come back, because sometimes that does take quite some time. So if the source patient is not available for testing, in other words, I reached under the cushion on a gurney and got stabbed in the hand by a bloody hypodermic needle, and we have no idea whose body that needle had punctured previously, you have to assume that that was HIV positive blood, and just not worry about finding a source patient. You have to assume that it's positive. As far as the HIV evaluation of the exposed individual, we also want to conduct rapid HIV antibody and antigen testing on the exposed individual to have a baseline. If you have a female exposed individual who may be at risk for being pregnant, it's always important to conduct a pregnancy test because that can have a significant impact on which antiretroviral medications are chosen. If the exposed individual knows themselves to be HIV positive prior to that exposure, we would just trust that that information would be shared with supervisory staff in complete confidence. And in that instance, post-exposure prophylaxis should not be administered. Monitoring for seroconversion is conducted with antigen antibody testing at 6 weeks, and then at about 3 months, and again at about 6 months. And any positive tests, of course, should be confirmed by Western blot. Other important information for exposed individuals is that if the source patient is known to be HIV positive or assumed to be HIV positive, if post-exposure prophylaxis can be initiated within 1 to 2 hours, that is considered optimal. Within 24 to 36 hours, 72 hours at the latest. After 72 hours, there's really some significant question as to whether post-exposure prophylaxis does any good at all. It's important for people that are going through that post-exposure evaluation to utilize condoms or sexual abstinence until the full 6 months of serial HIV testing is completed and is negative, and they should also refrain from blood, semen, or organ donation until all of that follow-up testing is completed and negative. So as far as HIV post-exposure prophylaxis, the duration is 28 days. The cost of that is covered by Samaritan's Purse. There are some baseline labs that should be repeated at the midway point of those 28 days and also at the end of that 28 days, and that just consists of a CBC with differential basic metabolic panel or a Chem7 and a liver panel or a comprehensive metabolic panel, which encompasses both of those things. So that's once again at baseline at 2 weeks and at 4 weeks. Right now, the CDC and the WHO recommend a 3-drug regimen for post-exposure prophylaxis that includes 2 nucleoside reverse transcriptase inhibitors, coupled with a boosted protease inhibitor. So tenofovir, 300 milligrams daily, at least for individuals with good renal function, and emtricitabine, 200 milligrams daily. Those 2 medications together are what make up the brand name drug Truvada, and then combine that with either raltegravir, 400 milligrams twice daily. That is what is in Samaritan's Purse's PEP kits, if there are any that are still out there in the field. Or the alternative to that is dolutegravir, 50 milligrams daily, which has the advantage of being a once daily drug. That's an acceptable substitute. But both tenofovir and dolutegravir are not recommended in pregnant patients because of the potential for teratogenicity. So it's always best in the event that the exposed individual is pregnant to consult a specialist, to call the number that's on the screen there for the National Clinicians Hotline for post-exposure prophylaxis. As I said, both tenofovir and dolutegravir are not a good idea for pregnant patients. The PEP kits that were out there, as I said, those had 3 rapid diagnostic kits for HIV, hepatitis B, hepatitis C, and pregnancy, along with an initial 10-day supply of medications. I would encourage individuals that are especially working outside the U.S. at a World Medical Mission facility to just make that a part of their onboard kind of check-in process to find out where the current status is of the testing ability and also the availability of those antiretroviral drugs. Once again, because access to that uninterrupted 28-day period of antiretroviral medication is considered essential, SP is encouraging that exposed individuals where there is reason to be concerned about HIV should make it back to their country of origin as soon as possible. so that prophylaxis is not interrupted. Next slide. For exposed individuals, the hepatitis B evaluation includes obtaining hepatitis B surface antigen level on the source patient as soon as possible if their status isn't already known. If the source patient is unavailable or considered high risk, they are to be assumed positive. So if the exposed person knows their surface antibody titer and it's greater than 10, then no further action is needed. If their titer is unknown and locally that diagnostic capability is there, draw a titer. It's important to know how long it's going to take to get that information back. If it's not possible locally to get the surface antibody titer, then you have to assume that they're a non-responder and give them hepatitis B immune globulin within 14 days. And again, there's a second dose that should be given about a month after the first dose. There are at least 3 different producers of hepatitis B immune globulin. The dose is pretty standardized. If there is no local access, I mean, I know we've been vaccinating a lot more of the international field staff, a lot of the apprentices who are going overseas, doing a lot more rabies vaccination just because of the unreliability of the rabies immune globulin. I don't know if in the field, if the hepatitis B immune globulin is significantly more available than that. So for non-responders, if they're found to have an antibody titer less than 10 milli-international units per milliliter, the hepatitis B vaccine series should be repeated. And of course, maybe 30 to 60 days after the 3rd dose of that repeat series, I would encourage people to get their surface antibody titer checked again to make sure that it's in that protective range. So as far as hepatitis C exposure is concerned, if the source patient is known to be hepatitis C positive or unknown and potentially positive, the exposed person should undergo the following baseline and follow-up testing. We encourage them to have a hepatitis C antibody assay done along with an ALT or a full liver panel at baseline. And then quantitative hepatitis C RNA assays to be performed 4 to 6 weeks post-exposure. That requires a more sophisticated laboratory in general. And then the anti-hepatitis C antibody along with the hepatitis C RNA and liver function testing 4 to 6 months post-exposure. If seroconversion does happen, it's recommended that referral to a gastroenterologist or a hepatologist be made to talk about the options for antiviral therapy to avoid the risk of hepatitis C progressing to include all of its complications. Some additional information. It's really encouraged that if there is any kind of blood-borne pathogen exposure in the field, that World Medical Mission leadership at Samaritan's Purse International Headquarters here in Boone be notified as soon as possible. That will help facilitate both a complete course of post-exposure prophylaxis in the event of HIV exposure, but also to help expedite travel arrangements when those need to be made. The medical director of our family medicine clinic here in Boone, that's me. I'm happy to act as a liaison to monitor just to make sure that people do complete the course of follow-up treatment and or laboratory monitoring, make sure that they've gotten the appropriate counseling, make sure they feel like they've received all the information that they need to avoid any kind of long-term consequences of an occupational exposure like that. And of course, the confidentiality both the source patient and the exposed individual will be guarded very carefully throughout that process. The next slide here, this is just my contact information for people to screenshot, or don't ever hesitate to email me or call or text if people need any additional information. We can certainly attach the post-exposure protocol packet to an email to anybody in the field who requests that. It's still undergoing some further fine revisions and just waiting a final okay from Dr. Plyler. But just before we go to the question and answer period here, I wanted to read something from 2 Samuel chapter 22. This is right after David had finally been delivered from the hand of all of his enemies and also from the hand of King Saul. And he says, starting in verse 2, "The Lord is my rock and my fortress and my deliverer, the God of my strength in whom I will trust, my shield and the horn of my salvation, my stronghold and my refuge." And I think especially for people who continue to just courageously go out into the field around the world and around the country, serving the Lord through Samaritan's Purse and through World Medical Mission, to have that shield, to know that the Lord has put these tools in our hands, that should an occupational exposure event happen, we're not helpless. We're not without God-given medications and other means to keep people in that fight, to keep people in the field, to keep them healthy for many more years of service to come.
Well, thank you, Dr. Hagen. Remember to post your questions in the chat box, and we'll be certainly happy to pass those on. That was great. Thank you, Steve. Is there, would you advocate then that pretty much any of our certainly medical providers or volunteers that are journeying out to the hospital should probably have their Hep B titers checked in advance?
Yeah, I mean, we're really encouraging, especially overseas staff who may not have access to that diagnostic test in a really timely fashion, to know at least within the last 12 to 24 months what is their surface antibody titer. And they can just request that of their primary care provider. They may even be able to request that from the employee health division if they work for a big hospital system. If they are not periodically having that checked in their home hospital system, it may not be a bad thing for them to advocate for.
Okay. Well, that's good to know. How about, do you have any idea at this time, and that's probably something that I can find out about the number of our partner hospitals that may have the PEP kits?
I actually just talked about that with Dr. Plyler yesterday, and he was not sure the answer to that question, because I actually asked that question, or I kind of, as part of our discussion, I was kind of assuming that a current PEP kit with a 10-day supply of antiretroviral medication and with 3 diagnostic tests for hepatitis B, C, HIV, and pregnancy was at each of those hospitals. But because World Medical Mission doesn't have complete overall control of a lot of those facilities, he could not answer that question for me. So I guess I would strongly recommend that for volunteers that are going overseas and working at a fixed medical facility like that, that they maybe ask some questions about that when they first report on board there. Talk to the medical director, talk to the director of nursing if they have one, and maybe talk to the pharmacy department, see what their supply of antiretroviral medication looks like, see if they have hepatitis B immune globulin on hand. So I honestly don't know the answer to the question, how many of the World Medical Mission hospitals have those kits on hand. They can be quite expensive, and the turnover of the components inside those kits can also make keeping them updated quite expensive. And fortunately, they're not needed very often, but when they're needed, it's like you kind of need them 10 minutes ago.
Yeah. Well, it's certainly something that that we'll keep pursuing on this end. It's interesting, the whole concept of our volunteers. I wonder how many of them, because so many of them are involved in different exposures, whether it's splashes or needle sticks, or how many of them have contemplated or have actually gone so far as to return home to do testing or post-exposure testing. I'm curious how many people are doing that, because that's certainly a great point that I'm guessing most folks are not. They're just praying for the best and not making that big effort to come on home.
They soldier on.
Yeah, exactly.
When I mentioned that to Carmen Ott is the nurse practitioner here at our clinic in Boone, and she and her husband David spent many years living in Africa, in I believe Chad and Sudan, and she just sort of chuckled when I suggested that people should plan to return to their country of origin to make sure that they complete. Of course, if you're working in an area where the need for antiretroviral medication is high and fairly constant, she didn't feel like there would be any problem getting the medication. And she also intimated that, would you really trust 100% the results of the laboratory studies that were done, or would you just take your 28 days or your 30 days of post-exposure prophylaxis and just keep working? So having not served overseas, unlike probably a lot of the people who are following along here, I can't really answer the question, what would I do if it was me?
Yeah. Dr. Steffies wrote in and made a good point that that's probably an important thing that we should work towards, is finding out how many of our hospitals have those, the costs involved, and how we could go ahead and at least pick our 10 or 15 most commonly volunteered hospitals and make sure they're prepared. Yeah. Let's see, he also wrote in the early 2000s, many volunteers used to carry the kits with them and left them for the hospital after they left if it wasn't used, because it was not widely available. So, very good. Well, I see no further questions. I know things are expensive out there, and we'll keep working on keeping y'all safe. I know we have a lot of volunteers that watch this or will be watching it in the future. Thank you again, Dr. Hagen. What an honor to have you here. Remember that CME credit is available for this session, and the form and instructions are in your email. And we'll be sending a follow-up email with a link to this recording. If you're not on our email list, you can join the forum at health.samaritanspurse.org. That's health.samaritanspurse.org, and be the first to know about upcoming events. Our next webinar will be Wednesday, September 9th, and Dr. Steffies, Bruce Steffies, who has been commenting on this broadcast, will be our guest, and he's going to discuss successful medication education in developing countries, so be sure to tune in. Thank you again all for joining us. Thank you, Dr. Hagen. And we look forward to you next time. Take care.